This chest X-ray shows cardiac pacemaker device with battery pack here in the right chest wall, and there are two leads, one projecting over the right atrium, the other projecting over the right ventricle. So this patient's leads were removed, and a subsequent examination was performed to see if there was any residual broken fragment of the lead that was left behind. So this is the CT that was performed, and this is the coronal non-contrast CT of the chest, and we can see there's a hyperdensity, linear hyperdensity, exactly at the same level where we saw these leads on the chest X-ray. But interestingly, the chest X-ray that was done after the surgery does not show any hyperdensity at that level. And if you recall from the prior pre-op radiograph, the hyperdensity of the leads is very well seen against the soft tissue density of the patient's body. So what is going on? Is there any retained lead? Let's find out. So this is the non-contrast chest CT that was done immediately after removal of the cardiac pacemaker lead device. So this pocket of air in the right chest wall subcutaneous plane is expected, and it's normal because of the recent post-surgical status, and small focus of air tracking along the path of the lead is also normal. What is not normal is if there was any fluid collection that would suggest a hematoma or an abscess. So thankfully there is no fluid collection, so that is all normal finding for the immediate post-surgical status. Now we'll track along the path where the leads were. So this is the uh, right IJ goes down and it becomes the right brachiocephalic vein. We'll keep tracking it down. It joins the left brachiocephalic vein here and becomes the superior vena cava. We continue tracking it down, and there's this hyperdensity which is present in the along the wall of the superior vena cava within the lumen though. And if you look on the coronal images, we can see this linear hyperdensity corresponds to the level of the cardiac leads that were present on the prior chest X-ray. And this measures approximately 4.8 centimeters in length. And if you draw ROIs over this hyperdensity, it measures around 325 Hounsfield units on this image. Let's look at the axial image. And on the axial image, you can see the density goes up to 470. So the density of this structure, this linear structure, is in line with bones. If you do the bone window, you can see the density of the structure is also similar to the bone. When there is a middle fragment, the density is way higher than bone. Also, there is a streak artifact that we tend to see around the middle fragment, which we don't see here. So this is actually calcification. And why is there a linear calcification exactly at the same location where there was a cardiac lead? So what happens is when the patient has these catheters or lead in the vein for a long time, there can be fibrin sheath deposition along the flow of the blood. So the blood flows along these uh, leads, and there's a normal expected fibrin sheath that deposits. Over time, when the fibrin sheath is there for a long time, there is dystrophic calcification over that fibrin sheath. And since the fibrin sheath has deposited along the catheter, it's linear in deposition. And so the superimposed calcification over those fibrin sheath is also linear and gives an appearance of a catheter that might be left behind. And usually it is more common in patients who are diabetic because they tend to have higher degree of dystrophic calcification. So this basically is a fibrin sheath calcification that is present, and there is no retained catheter there. Now, this fibrin sheath calcified fibrin sheath can give rise to two common complications. One of them is if this calcification gets big enough, because once there is dystrophic calcification, there is chances of it accumulating more calcium over time, and this deposited calcium can become so big in size that it can cause vascular occlusion. So that's one complication that can happen. The other complication that can happen is this calcified fibrin sheath. This can break, and once it is broken down, it can go down from this superior vena cava into the right atrium, then subsequently into the right ventricle, and go into the pulmonary trunk and lodge itself as a pulmonary emboli. So that's another second complication. That calcified fibrin sheath can cause. So putting everything together in this particular case, there was no retained catheter after removal of the cardiac pacemaker device. There was no retained lead. In fact, there's this fibrin sheath that calcified and was falsely called as the retained catheter or the retained lead while it was just a calcification. Thank you.